Hi, everyone. Thank you for joining us today for this very important discussion about managing pain after surgery. I'm Courtney Hunter, Vice President of State Policy at Shatterproof, and I'm pleased to be joined by the Shatterproof Founder, Chairman, and CEO, Gary Mendell. Today's event is brought to you by our partners at Choices Matter, a national movement designed to educate and empower patients to have proactive discussions with their clinicians about available non-opioid options for managing post-surgical pain. So we have a lot to get to. We're going to dig in right away. And Gary, I'll start off by asking, can you talk a little bit about how the COVID-19 pandemic has exacerbated the opioid crisis and the addiction crisis, and just what you're hearing and seeing, in your role?
Sure. It's almost too tragic to even answer the question. Recent data shows in the month of May, overdoses were up 42% year over year, May 2020 from May 2019. I mean, it's beyond anything that I can almost even talk about, how this is affecting those who are addicted and those who are becoming addicted because of the social isolation that's so needed to protect yourselves from COVID. So I'm not recommending against it, obviously, but the loneliness, the being alone is creating much higher rates of alcoholism, much greater rates of drug use. And for those who are already addicted, no one there to help you. And then add on to that, the anxiety of losing your job, the anxiety of having just lost your job. Can you pay your rent? Are you out on the street? All these issues that come with it. All these issues. So it's making it that much worse. And it makes it even more important now if we have opportunities to prevent people from becoming addicted. We need to take advantage of those.
What role can non-opioids after surgery play in mitigating the opioid epidemic?
Sure, really an enormous role, Courtney. And to all those listening, I mean, there are 70 million operations a year, 70 million operations a year, and 90% of those, 9 out of 10, 63 million of those operations, there's an opioid prescribed. And the vast majority of them don't need to have an opioid prescribed. And we look at those 63 million where an opioid was prescribed, literally 1 out of 10 of those people, 6 million, 6.3 million in round numbers, 3 to 5 months later, they're having an issue being addicted to that opioid. That's 6 million people. That's 6 million families. And a large number of those it didn't need to happen.
It's still amazing to me how we're in 2020, we're amidst the pandemic and also the ongoing opioid epidemic, that we still have a surplus of opioid pills that are being prescribed. What more needs to be done in terms of, educating people, consumers, but also, physicians on non-opioids?
Sure. For me, it's been a learning experience as I founded and started Shatterproof, about how change takes longer amount of time than I'm used to in the business world. And in running a company, you want to make a change, you implement a policy and it gets done. And it would seem so logical that for those 63 million who are prescribed an opioid, that we could put a policy in place to educate our healthcare industry, to educate their consumers, their patients, if you will, about non-opioid options, and let the patient decide based on the pluses and minuses, the risks and benefits of each. But it's just not happening. It's just not happening at a pace that we would all expect. And frankly, it's shocking.
And what happens to all of those leftover pills after surgery when they're left in the medicine cabinet, and what can we do as community members and family members to keep our loved ones safe?
Sure. Great question again. The reality is that the overprescribing of opioids, which for those people who don't know, went up 4 times, not 40%, 400% over a period of 15 years, from the late 90s to for the next 15 years. And overdose deaths went up the same rate, about 4 times. So this is a real issue, number one. What can we do? Well, those 63 million people that were prescribed an opioid after a surgery, as we just spoke about, they should be educated, and many of them will decide not to take an opioid, and that takes the risk right off the table. Then the question to to your specific question, for those who were prescribed an opioid, many don't take the full prescription. I mean, those prescriptions, um, they were 80 pills each on average, 80 pills each. Some people will take it for 2 or 3 days and have numerous pills left over. But most people think, I may sprain my ankle, I may pull a muscle 6 months from now. Let's keep that pill, let's keep the bottle of pills around. What they don't realize, because they just don't think about it, and we haven't been educated this way as family members, of how dangerous that could be. I mean, there's not a family in America, there's not a parent in America that will go out on a Saturday night and leave their teenagers at home and leave a loaded gun on the kitchen table and tell their kids, don't touch the gun. There's not a family in America. But parents all over the country go out on a Saturday night, leave their high schoolers at home with a bottle of pills in the medicine cabinet. And it's not that they're bad parents, they just haven't been educated to understand that how dangerous this could be. And if you're a teenager, you're thinking this has to be safe. It was prescribed by a doctor. I mean, it's just the whole education of how we think about it and handle it is just backwards. And many of those teenagers will try a pill. Some will become addicted, some won't. But for every one that does, just one funeral, it's one too many.
Yeah, absolutely. And it's still amazing to me that we have a lot of work to do in terms of increasing the perceived risk that's associated with opioids. Unfortunately, I don't think they're going to come off the market anytime soon. I would like for FDA to do that, but there's still, a chronic pain community and people who will advocate for that. So we need to do our work in educating people on the risks. And with that, why do you feel it's so important, Gary, to educate about non-opioid options to manage pain after surgery in particular?
Sure. In most cases, we as family members don't need to educate ourselves about different ways that medicine can treat an injury or an illness, because our healthcare providers have been taught in medical school the right way to handle things. In this particular case, it hasn't happened in a way that should be throughout our healthcare industry. So this is a circumstance where we need to, as our healthcare system is beginning to educate providers on this, we need to take it upon ourselves, and we're doing that with Choices Matter, to go directly to the families and educate them, because it really could mean the difference of life or death.
And particularly for all of those millions of Americans, 22 million of Americans who are in recovery from addiction, who are afraid to go in for a surgical procedure, that they might be re-exposed to an addictive substance, and sometimes unwillingly, particularly with a dental procedure or something of that nature. Not sure if you've heard of that, but I certainly have friends and family members in recovery who are terrified to have something happen to them where they would need surgery and be re-exposed.
Absolutely. And like, it's a great point, Courtney. Not only do we need to educate families so they understand that there's an option if you're having surgery, there is an option for a non-opioid, which would then, for every 10 people that decide not to do that, that eliminates one that would ultimately become addicted. And secondly, exactly to your point, how many people never have surgery because they're afraid of becoming reintroduced to an addictive drug? And what kind of life do they live if they have something that needs surgery and they're afraid to get it? It's just all the more reason, just doubles down on the reason. Simply educating families about this so they have a choice. Choices matter, but they have a choice. And they can decide based on the risks and benefits um, described to them by their provider, they can make a choice whether to take an opioid or not. But ultimately, in addition to families, providers need to understand this. And we also need to change the way that non-addictive drugs are paid for. So the healthcare system is incentivized versus disincentivized to use them.
And so oftentimes the choice is made for them in a hospital setting. There, isn't an alternative that's offered to a patient. I've also heard, I don't know if you've heard this anecdotally, but people, saying to their physician, "I'm in recovery from addiction. Please don't give me an opioid," and still being prescribed an opioid. So there's definitely, you're right, there's definitely a big learning curve there on the provider side as well, to understand and acknowledge the importance of addiction as a chronic disease. Um, and so with that, why aren't non-opioids being used more by physicians? And particularly given, just the availability of non-opioids and the positive impact and clinical outcomes that they have on patients.
Sure. It's something that is practical, but in this case, so wrong, or it doesn't fit. It's called bundled payments. And the healthcare industry over a period of years has, wherever they can, they bundle services together for one payment. So you go in for a knee surgery, instead of saying, the day before the checkup is X dollars, the day of it's thousands of dollars, recuperation is a little more, medication is X, they bundle it. And they say $10,000 for your whole surgery from the first visit you had in your primary care office right through to full recovery. I'm just picking a number out of the air, but to describe this. So it's a bundled payment, X dollars for the whole thing, soup to nuts. So if you're a doctor who's going to operate on someone and you're getting $10,000 for a procedure from beginning to end, or your hospital is getting $10,000 for a procedure beginning to end, and the medication is part of that bundled payment, are you going to take a $5 generic opioid as part of that bundled payment, or are you going to do a more expensive non-opioid that's not generic? And I also want to add that it's my belief, and I think it's pretty well founded. Doctors get into the field of medicine. People work in hospitals in the field of medicine because they want to help people. These are good people. But when you have this large disincentive to prescribe a $3 to $5 non-opioid, generic non-opioid, versus a $3 to $5 generic opioid versus a non-opioid, which is a few $100s, but in the long run will save billions of dollars of healthcare cost. And so fewer families being in a cemetery burying a family member. It's as no-brainer as you get. But trying to get the policymakers in Washington, because it usually starts with Medicaid and Medicare, and then it moves to commercial insurance, to change that policy, it's just not easy because they're against anything that unbundles. That's the
I wish
reality.
Yeah, I wish we could get them to think more long term instead of the short term benefit, because that's exactly what you're talking about. Is we could be, opening up the door to addiction for so many families, and unnecessarily so. Um, what, in your opinion, Gary, what more can be done to, to educate consumers? It's very difficult for, I think, patients to be their own advocates. And so how can we help people do that, in your opinion?
Sure. Well, we're doing that now with Choices Matter, which is, um, Shatterproof has now grown since we started, and we're getting a lot of activity, people coming to our website to learn about addiction. So we have information there about non-opioids. We are continually um, writing stories, blogs, if you will, about people who've had an issue with opioids. There's also people who could have taken a non-opioid, or people who've taken a non-opioid and it's been a great experience. And so getting that information out in personal stories that people tend to read more and get the word out is a way to do that. So that's a second way. One is on our website. Two is through all our channels of getting information out. Third is we have at Shatterproof, we have events around the country. This year, obviously, they're not physically in person because of COVID, but we've had a lot of events, and we are this year virtually. So getting this information out in these form of events where we get a large collection of people attending is another way to educate the public. So that's three ways off um, that we are currently doing with Shatterproof, and we look to do more.
And are there any other resources that Shatterproof has that we can share to help those in recovery?
Sure. Well, one of the biggest things to help people in recovery and those in struggling with addiction is changing the way that people think about this disease. Ending the stigma that's associated with the disease, with the people who are afflicted with the disease, their families, the medications that treat the disease. All this can be changed. And we spent 2019 working with McKinsey and Company, and really we researched 11 social movements of how changes were made. How did our country change its views on marriage equality? 20 years ago, you couldn't even join the Boy Scouts if you were gay. Now you can run for president. Well, what things worked in that movement and what things didn't work? We studied HIV/AIDS. We studied how our country changed the way teens smoke and versus not smoking. We looked at 11 movements, and we developed a plan to do so. So without going into the details of the plan, we are now beginning to implement it. Starting out in the state of Pennsylvania, we just launched our statewide campaign for the next 12 months. So we're just beginning. But that's one way that we can help people in recovery so they're not ashamed. Um, the worst thing that can happen is that someone develops an illness like addiction, no different than diabetes or asthma or heart disease, and gets treated and enters society and lives in a society where literally 8 out of 10 Americans, backed up by a recent survey, don't want to associate with someone addicted as their friend, their coworker, their neighbor, marrying into their family. Well, this is a very treatable disease, preventable and treatable disease. And so, how do you live knowing that most people don't want anything to do with you? How do you live a full life and a happy life without losing hope, without starting to internalize those messages you're getting from everywhere and starting to believe that you're not worth it, that you're not worthy of being someone's friend or coworker, and losing self-esteem and hope? So that's a real way that we can help people recovery. In my view, the most important. So it's viewed just like somebody with diabetes. You have a treatable disease.
No, thank you. Thank you for that, Gary. I couldn't agree more. And I think, this conversation also just illuminates the need for more prevention. 90% of addiction begins in the teen years. So how are we staving off our next generation from becoming addicted to substances. And that also begins by limiting the amount of prescription opioids that have been shown to cause addiction. So I really appreciate, the focus here on non-opioid alternatives, and everything that I'm so proud to be a part of the Shatterproof team and everything that Shatterproof's doing to help consumers, and also working with the provider community to educate them on the alternatives that are out there, so we can reduce the amount of opioids that are in our medicine cabinets.
Absolutely. And if I can just go back to what we touched upon earlier, we absolutely need to educate families, and that's what we're doing with Choices Matter. But we can also be educating providers.
Just back to what we were talking about with COVID, I couldn't agree more that there's never been a greater need, for more resources, but also, for people that are in recovery. It's such a challenging time, and easier time, right, for people to fall into relapse. And so we need to be very cognizant of that in providing resources and having options for people, who are struggling, and their families as well. So, can you talk a little bit about the recovery community and how what the importance is of having alternatives for the 22 million Americans that are in recovery from addiction, and what this access would mean to that community?
Sure. I first want to go back to one thing you said when we talked about providing more resources for people who may be in need. We need some resources in some places, but I just want to stress that the data is pretty clear. We don't need more money to this. We need the money that's there being used smartly. Basic blocking and tackling, logical implementation of smart policy. Unbundling non-opioids. Secondly, related to the 22 million people who are living in recovery, the first thing that we can do is educate them, because many of them will need a surgery at some point. As we talked about earlier, that you don't have to be afraid to take surgery, that you're going to be exposed to an opioid. Meet with your doctor, understand the non-opioids that are available, discuss with your doctor if that's viable for your type of operation. And if it is, without any shame or judgment, have a surgery with a non-opioid where you really didn't need it. We didn't need an opioid. That's not in every circumstance, but it's in many of them. So that is really important to educate those in recovery about the options. And I just can't finish a sentence talking about those who are in recovery without coming back to the other big thing they need, which doesn't cost any money. It's changing the way that we think about this disease so they don't feel any shame or judgment. Like I've talked to thousands of people who are addicted in the last 10 years. I have never met one, not one, who said they reached to the sky one day and asked God to addict them. It happened. They deserve medical care for a chronic illness, a treatable chronic illness, just like any other American with any other disease.
Yeah, absolutely. And bringing addiction into the medical mainstream also means having treatment options available for all patients, which is not currently the case for addiction. So we have some work to do on that front. And even if, a person in recovery knows what the options are and goes in for surgery, it still might not be, an available resource to them to have a non-opioid, because of hospital policy or some of the regulatory barriers that we were talking about. So, it's how much more of an informed consumer do you need to be if the policies aren't aligned? And so, that's why we're so supportive of this legislation, and changing the policies to really incentivize providers and health systems, to choose to choose options that are not addictive.
Absolutely. And that's what we're doing at Shatterproof.
Well, thank you so much. I enjoyed the conversation. Is there anything else that you'd like to add?
In closing, I'd like to add that addiction is not about, I can't look anybody in the eye and say that we can end addiction tomorrow. But I can look everyone in the eye and say that we can cut this in half tomorrow. Cut this in half, save 40,000 lives next year, 40,000. And the hundreds of thousands of people who won't die but live subpar lives by simply executing and implementing common sense policies. And one of them sitting right in front of us is the unbundling of and disincentivizing non-opioids for surgery. 63 million people prescribed an opioid when many of them didn't need it. Is that as common sense, as logical as we need? So thank you.
Couldn't agree more. Couldn't agree more. Well said.